Yeah, hi, I'm Jon Gruber. I'm a professor of economics at MIT, and I've worked in healthcare policy for a long time.
Fantastic. So tell me about the topic that you're looking at in your brief.
Yeah, so the topic I'm looking at in this brief, is trying to understand whether there's a way to create what I call smart networks. So the idea is that basically, we look at health insurance today, we have two kinds of plans. We have broad network plans and narrow network plans. Broad network plans are traditional plans where essentially you can go to any doctor you want, or most any doctor you want. Narrow network plans are plans which limit which doctors you can go to. Now, narrow network plans have been shown to be effective in controlling costs, but a lot of people don't like them because they're afraid if they get really sick, they'll be stuck going to a doctor that's not as good. The idea of smart networks is to try to compromise by setting up a network where, for services which CMS calls shoppable, services like MRIs, where there shouldn't be a huge quality differentiation across providers, we try to have a narrow network and people go to less expensive providers. But for other services where we think quality might matter more, you would go to a broad network. And to understand what difference that could make, we tried to take this list of shoppable services to the HCCI data.
So what are the savings? So you introduce these smart networks. You basically say, look, we'll take the CMS shoppable services and reimburse it at the median. What happens?
Yeah. So what we do, as you said, Zach, is we take the list of the 70 shoppable services CMS designates. Let me say, I think this is a somewhat conservative list, but this is the things they say are certainly shoppable. We go to the HCCI data and we ask, okay, imagine if for all these services, everyone paid the median, not the lowest, but the median cost in their area for this service. And we find is doing so just for those 70 shoppable services would lower healthcare spending by about $30 billion. So it's a pretty significant effect for only the 70 sort of clearly shoppable services and only going to the median. That also, for example, ignores the fact that once you add a system like this, providers might compete to lower prices further. So I think this is a pretty conservative estimate.
For sure. So where did the idea come from?
Well, I mean, I think the idea really just came from, it's just an extension of the idea of narrow networks. It came from the fact that I have done research. I'm a big fan of narrow networks, but I understand that there's two problems. One is that people don't like them, and it's hard to really get the fundamental change you need when people are fighting them. The other is that, as work by Mark Shepard and others have shown, they can be used as a tool for discrimination in insurance plans to try to get rid of your sickest patients by, for example, excluding the good cancer hospital. One way to address both of those is to say, let's have the narrow networks where those concerns aren't large, and let's move to broader networks where those concerns do exist.
Fantastic. Well, thank you for doing the brief.
You bet. My pleasure.